What if you had already had a heart attack and you simply didn't know it? Not a hypothetical, not a worst-case scenario designed to frighten you. A documented, peer-reviewed, clinically confirmed medical reality that affects millions of Americans over the age of 60 right now, today, as you are watching this video. Researchers have a name for it. They call it a silent myocardial infarction. And the reason I need you to stay with me for the next several minutes is because the people most likely to have one, and most likely to never know, are adults in exactly your age group, living exactly the kind of life you are living, feeling exactly the way you feel right now. I am Dr. Pablo. I am a board-certified geriatrician with 18 years of clinical experience working with adults over 60, with a focus on cardiovascular health and the specific ways the aging heart becomes vulnerable in ways that standard medicine often misses until it is too late. Here is what I want you to hold on to as we go through this together. The number one point on this list, the single most dangerous mechanism driving silent heart disease in adults over 60, is something that almost no one is talking about. Not your primary care physician at your annual physical, not the health segments on the evening news. I will get to it, but I need you to understand the full picture first, because without that context, the number one point will not land the way it needs to. Let us start with the data, because the data is where the story begins, and the story is not a comfortable one. A landmark study published in the Journal of the American Medical Association followed over 9,000 adults and found that nearly 45% of all myocardial infarctions, heart attacks, went completely unrecognized by the patients who experienced them. No chest pain, no left arm heaviness, no cold sweat, no collapse. Nothing that the person experiencing it would have labeled a medical emergency. The damage was only discovered later, incidentally, through an electrocardiogram or cardiac imaging done for an entirely different reason. And here is the part that should stop you cold. Those individuals who had silent heart attacks had 3 times the risk of dying from heart failure in the years that followed, precisely because they never knew to change anything, never knew to start a medication, never knew their heart had already been wounded. Now you might be asking, why silent? Why would a heart attack produce no pain? The answer lives in the biology of aging, and it is important that you understand this because it reframes everything about how you think about your own cardiovascular risk. As we age, the sensitivity of cardiac pain receptors, the nerve fibers that would normally scream when heart muscle is being starved of oxygen, diminishes. This process, called cardiac autonomic neuropathy, is accelerated in people with diabetes, in people with long-standing hypertension, and in people who have spent decades with mildly elevated inflammatory markers that no one ever aggressively treated. The alarm system does not ring. The fire spreads, and the person goes to bed that night thinking they had an unusually tiring day. There is a second mechanism, and I want you to understand this one too. In younger hearts, a blockage in a coronary artery produces an intense, unmistakable event because the collateral circulation, the backup blood supply, has not yet developed. But in older hearts, years of gradual narrowing have often stimulated the growth of small collateral vessels around the blockage. These vessels keep just enough blood flowing to prevent the dramatic, crushing chest pain, but they are not enough to prevent the muscle from dying. The heart attack still happens. The damage is still real. The scar tissue still forms. The person just never felt it happen. This is why I want to walk you through 6 specific warning patterns. Not symptoms in the traditional sense, but physiological signatures and risk trajectories that, taken together, tell you whether your heart may already be in danger without announcing it. We are going to go from number 6 down to number 1, and as I said, number 1 is the one that changes everything. Number 6, exertional fatigue that you have normalized. There is a 68-year-old man I want to tell you about. His name was Gerald. Retired letter carrier from outside of Columbus, Ohio. Spent 31 years walking routes in every kind of weather, so he considered himself fit. He came to my office not because anything was wrong, he was quick to tell me, but because his daughter had insisted after noticing he stopped taking his evening walks. When I asked him about it, he said the walks just tired him out more than they used to. He said he figured it was his age. He said, and I remember this clearly, "Dr. Pablo, I am 68 years old. I am supposed to be tired." Gerald's resting EKG showed Q-wave changes in the inferior leads, the electrocardiographic fingerprint of a prior myocardial infarction involving the right coronary artery. Further imaging revealed that Gerald had almost certainly experienced a silent heart attack somewhere between 14 and 22 months before sitting in my office. The fatigue he had normalized, the walks he had quietly given up, the afternoons he now spent sitting rather than moving. None of that was aging. All of it was his heart telling him, in the only language it had left, that something was wrong. The physiological mechanism here is called reduced cardiac output reserve. When a portion of the left ventricle has been scarred by a previous infarction, the heart can maintain adequate function at rest. The numbers look acceptable. The resting heart rate is fine. The blood pressure is normal. But when demand increases, when you climb stairs, when you carry groceries, when you walk faster than a stroll, the scarred muscle cannot contribute. The healthy muscle overcompensates, and the result is fatigue that arrives earlier and lingers longer than it ever used to. Research published in the European Heart Journal found that unexplained decline in exercise tolerance in adults over 60 was associated with a significantly elevated risk of undetected coronary artery disease, even in individuals with no traditional symptoms and no prior cardiac history. If you used to do something physical without effort, and now you avoid it because it tires you, do not call that aging. Call it a conversation your heart is trying to have with you. Number 5. Jaw pain, neck tension, or upper back discomfort that appears with exertion and disappears with rest. The heart does not always speak in the language of the chest. This is one of the most consequential misunderstandings in cardiovascular medicine, and it costs lives every single year. The pain fibers from the heart travel through the same neural pathways as fibers from the jaw, the neck, the left shoulder, and the upper back. This phenomenon is called referred pain, and in older adults, particularly in women over 60, where this pattern is dramatically more common than the classic chest pressure, it is the primary presentation of active ischemia. Margaret was 71 years old. She had been a dental hygienist for 34 years, so she understood oral health better than most patients I see. She came to me because she had been experiencing what she described as a deep jaw ache on her left side, always during her morning walk, always gone by the time she had been sitting for 10 minutes. She had seen her dentist twice. Her teeth were fine. She had been prescribed a night guard for what was presumed to be bruxism, teeth grinding. She wore the night guard faithfully for 4 months while the real cause continued unaddressed. A nuclear stress test confirmed significant ischemia in the lateral wall of her left ventricle. Margaret had 2-vessel coronary artery disease. She went to the dentist twice. She needed a cardiologist. A review published in Circulation found that atypical presentations of cardiac ischemia, meaning pain or discomfort occurring in locations other than the chest, accounted for nearly a third of all missed diagnoses in adults over 65, with women disproportionately affected. If you have discomfort anywhere from your earlobes to your navel that appears predictably with physical effort and resolves reliably with rest, that is the pattern. That is the pattern that deserves a conversation with your doctor this week, not next month. Number 4. Sleep disruption caused by shortness of breath. This one is subtle, and it is subtle in a way that makes it particularly dangerous, because most people over 60 expect their sleep to be imperfect. You wake up more often, you sleep lighter. You attribute it to stress, to needing the bathroom, to the fact that you are simply not 35 anymore. And sometimes that attribution is accurate. But there is a specific pattern I want you to know, because it is a red flag that can easily be mistaken for ordinary aging or even anxiety. It is called paroxysmal nocturnal dyspnea. It happens when fluid that has been pooling in the lower extremities during the day, in ankles, in calves, in the soft tissue of the legs, redistributes into the circulation when you lie down to sleep. In a healthy heart, this fluid shift is managed without difficulty. In a heart that has been silently damaged and whose left ventricle is no longer pumping efficiently, this fluid backs up into the lungs. The result is a sensation of breathlessness, sometimes accompanied by a dry cough, sometimes presenting simply as an inability to sleep lying fully flat, a preference that develops gradually for more and more pillows. Thomas was 64 years old, former high school football coach from outside of Birmingham, Alabama. His wife brought him in, and she was the one who described the symptom because Thomas himself had not connected it to anything medical. She said he had gone from 1 pillow to 2 pillows to 3 pillows over the course of about 8 months, and that some nights she would find him in the recliner in the living room because lying flat made him feel, in his words, like the air in the room was thinner than it should be. Thomas had not mentioned this to anyone. He thought he was getting reflux. He had actually purchased an extra wedge pillow from a home goods store and considered the problem solved. His echocardiogram revealed an ejection fraction of 41%, the ejection fraction being the measure of how much blood the left ventricle pumps out with each beat, with normal being above 55%. Thomas had heart failure with reduced ejection fraction, almost certainly the downstream consequence of one or more unrecognized ischemic events. The recliner was not a comfort preference. It was his body keeping him alive. Research from the American Heart Association has documented that orthopnea, the need to sleep elevated to breathe comfortably, is one of the earliest detectable signs of left ventricular dysfunction in community-dwelling adults, and that the average time between symptom onset and medical evaluation in patients over 60 is 14 months. 14 months. If the number of pillows you sleep with has increased over the past year, if you find yourself more comfortable in a chair than in a bed, if you wake in the night with a cough that has no other explanation, please do not file that under aging. File it under cardiology appointment. Number 3. Ankle swelling that appears in the evening and is gone by morning. I want to be precise here because not all ankle swelling is cardiac. Standing for long periods causes swelling. Certain blood pressure medications cause swelling. Heat causes swelling. But there is a specific pattern that I want you to distinguish from all of those, and the distinguishing feature is the timing and the bilateral symmetry. When both ankles swell predictably by late afternoon and deflate overnight when you are horizontal, and when this pattern has developed or worsened over a period of weeks to months, that is peripheral edema driven by venous congestion. And venous congestion in an older adult is frequently the visible surface of a deeper cardiac problem. The mechanism is this. When the right side of the heart is not pumping efficiently, whether due to its own damage or because it is compensating for a struggling left ventricle, blood backs up in the systemic venous circulation. Gravity pulls that backed up fluid downward, into the ankles, into the feet, sometimes into the lower legs. During the night, when you are lying flat, gravity no longer pulls it downward. The fluid redistributes. The kidneys process some of it, and by morning, the swelling appears to have resolved. This cycle of swelling and resolution can continue for months before anyone identifies it as a cardiac warning sign. And during those months, the underlying disease continues to progress. Carol was 73 years old, retired librarian, grandmother of 4. She mentioned the ankle swelling to her primary care physician almost as an afterthought during a visit that was primarily about her knee arthritis. Her physician attributed it to the arthritis, to her age, to the fact that she was on amlodipine, a calcium channel blocker, which does list edema as a side effect. The amlodipine explanation was not unreasonable, but what was unreasonable was that no one ordered a BNP level, a blood test that measures a hormone released by the heart when it is under stress, or an echocardiogram. Carol came to me 14 months later after an emergency hospitalization for acute decompensated heart failure. Her cardiac function had been declining for well over a year. The swelling was not the amlodipine. The swelling was her heart asking for help in the only way it could. If your ankles swell in the evening, ask your doctor specifically about a BNP test and a cardiac echo. Not because swelling always means heart disease, but because when it does mean heart disease and no one checks, the consequences are severe and often irreversible. Number 2. A resting heart rate that is quietly increased over time. This one requires you to think back, and I recognize that not everyone has been tracking their resting heart rate over years. But if you have any data points, an old physical, a fitness tracker you wore for a period, a wellness app with historical records, I want you to look at them with fresh eyes after watching this video. Because a gradual, sustained increase in resting heart rate over months or years is one of the most underappreciated early markers of declining cardiac function in adults over 60, and it is almost never discussed in the context of silent cardiovascular disease. Here is the mechanism. When the heart's pumping efficiency declines, when each beat is delivering slightly less blood than it once did, the autonomic nervous system compensates by increasing the heart rate. The goal is to maintain adequate cardiac output, the total volume of blood delivered to the body per minute. If each beat delivers less, the heart beats more often. This compensation works for a while, and during that while, the person feels essentially normal. Their blood pressure is acceptable. Their energy is reasonable. Their resting heart rate has simply drifted from 62 beats per minute to 71 to 78 over the course of 3 years, and no one has flagged it because each individual reading still falls within the broad definition of normal. A cohort study published in the European Heart Journal tracking over 29,000 adults found that each 10 beat per minute increase in resting heart rate was associated with a 16% increase in cardiovascular mortality, independent of other risk factors. Independent, meaning even after controlling for blood pressure, cholesterol, smoking history, and diabetes, the heart rate itself carried its own prognostic weight. Frank was 66 years old, a retired electrician from outside of Phoenix, Arizona. He wore a fitness tracker religiously, had for years because he liked the data. When I reviewed his historical heart rate trends during his first visit with me, his resting heart rate had climbed from 64 beats per minute 3 years earlier to 81 beats per minute at the time of his appointment. He had never noticed the trend. Each number taken individually seemed unremarkable. The trend, however, told a clear story. Frank's subsequent workup revealed significant diastolic dysfunction and early coronary artery disease. The fitness tracker he wore for the step count data turned out to contain 3 years of quiet cardiac history that likely saved his life. Know your resting heart rate. Track it over time. If it has been climbing, even within the range of normal, that trajectory deserves attention. And now, number 1. The silent killer that almost no one in your life has told you about. The mechanism that underlies and amplifies every single point I have made so far. The reason that silent heart attacks are more common, more dangerous, and more deadly in adults over 60 than in any other age group. Chronic systemic inflammation. I want to say that again because I need you to understand that I am not speaking in metaphors. Chronic systemic inflammation, measured clinically by a blood test called high-sensitivity C-reactive protein, or HSCRP, is now recognized by the American Heart Association, by researchers at Harvard Medical School, by cardiologists publishing in the New England Journal of Medicine, as a primary driver of atherosclerosis, the progressive narrowing and hardening of coronary arteries that precedes both silent and symptomatic heart attacks. And in adults over 60, chronic inflammation is not rare. It is not a disease state reserved for people who are visibly unwell. It is extraordinarily common, frequently undetected, and almost never the subject of a direct conversation between a physician and a patient. Here is what inflammation does to your coronary arteries. The inner lining of your arterial walls, the endothelium, is a living, dynamic tissue. When it is chronically bathed in inflammatory molecules, it becomes permeable. LDL cholesterol, the bad cholesterol, infiltrates the arterial wall. Immune cells arrive to address the intrusion. The result is the formation of atherosclerotic plaque, a buildup of cholesterol, immune cells, calcium, and fibrous tissue inside the artery wall. Over years, this plaque narrows the artery. But more dangerous than the stable, narrowed artery is the unstable plaque, the plaque that is inflamed at its core, covered by a thin, fibrous cap that can rupture without warning, releasing its contents into the bloodstream and triggering the sudden clotting cascade that causes a heart attack. And in adults with high levels of chronic inflammation, these plaques are more numerous, more unstable, and more prone to rupture than in individuals with lower inflammatory burden, regardless of cholesterol levels, regardless of blood pressure, regardless of whether the person feels sick. The Jupiter trial, a landmark randomized controlled trial involving nearly 18,000 participants published in the New England Journal of Medicine, demonstrated that adults with normal LDL cholesterol but elevated hsCRP had dramatically elevated cardiovascular risk, and that treating the inflammation reduced heart attacks and strokes significantly. Normal cholesterol, elevated inflammation, significant risk. This is the combination that is walking around in millions of Americans over 60 right now, completely undetected, because hsCRP is not part of a standard lipid panel, is not routinely ordered at most annual physicals, and is not something most people have ever asked their doctor about. Now, before I give you the practical steps, and I will, specifically and with exact timing, I want to pause here and ask you something. Write your age and where in the world you are watching from in the comments below. I read every single comment on this channel. I want to know who is in this audience because everything I say here, I say with a specific person in mind, and that person is you. The drivers of chronic inflammation in adults over 60 are not mysterious. They are not inevitable. They are modifiable. And this is where I want to give you something concrete and actionable, because information without action is just anxiety. Here is what the research supports, specifically and practically. First, sleep duration. A meta-analysis published in the Journal of the American College of Cardiology found that adults who consistently slept fewer than 6 hours per night had significantly elevated hsCRP levels compared to those sleeping 7 to 8 hours. Sleep is not passive recovery. It is the period during which your body suppresses inflammatory signaling, clears metabolic waste from tissues, including the vascular endothelium, and resets the autonomic nervous system toward parasympathetic tone. Protecting your sleep is not a lifestyle preference. It is cardiovascular medicine. Second, visceral adiposity, specifically the fat stored around the abdominal organs. This fat, called visceral adipose tissue, is metabolically active in a way that subcutaneous fat, the fat under your skin, is not. Visceral fat secretes inflammatory cytokines continuously, including interleukin-6 and tumor necrosis factor alpha, which drive endothelial dysfunction and plaque instability. Waist circumference above 40 inches in men and above 35 inches in women is the clinical threshold associated with significantly elevated cardiovascular inflammatory risk, independent of overall body weight. Third, omega-3 fatty acid intake. A study published in the Journal of the American Heart Association found that adults with higher circulating levels of EPA and DHA, the long-chain omega-3 fatty acids found in fatty fish like salmon, mackerel, and sardines, had measurably lower hsCRP levels and reduced rates of major cardiovascular events. The anti-inflammatory effect of omega-3 fatty acids operates through multiple pathways, including the suppression of arachidonic acid metabolism and the production of specialized pro-resolving mediators that actively turn off inflammatory signaling. 2 to 3 servings of fatty fish per week, or a high-quality omega-3 supplement, providing at least 1 gram of combined EPA and DHA daily, is the evidence-supported target. Now let me give you a specific, practical evening routine, because the evening hours, research suggests, are when several of the most important cardiovascular protective behaviors can be concentrated. At 6:30 in the evening, with dinner, include 1 serving of a fatty fish or take your omega-3 supplement. By 7 o'clock in the evening, finish eating. Late eating elevates inflammatory markers and disrupts the overnight metabolic reset that the cardiovascular system depends on. At 8 o'clock in the evening, take a 10 to 15-minute slow walk, not for cardiovascular conditioning, but for glucose clearance and vagal nerve stimulation, both of which reduce overnight inflammatory burden. At 9 o'clock in the evening, dim the lights in your home. Bright light exposure in the 2 hours before sleep suppresses melatonin, which is not only a sleep hormone, but also a potent antioxidant that protects the vascular endothelium. By 10 o'clock in the evening, be in bed with the intention of 8 hours of sleep. And in the morning, before anything else, before coffee, before the news, before the weight of the day arrives, spend 5 minutes breathing slowly and deliberately. Inhale for 4 counts, exhale for 6 counts. This simple practice has been shown in research published in Psychophysiology to measurably reduce sympathetic nervous system tone and lower circulating inflammatory markers with consistent practice over 4 weeks. And there is one more thing I want to tell you, something that does not appear in most videos on this topic, something that sits at the intersection of cardiovascular biology and the specific reality of growing older, in a way that I think deserves to be said directly. The adults most at risk for silent heart disease are not the ones who have been reckless with their health. They are, more often than not, the ones who have been quietly responsible, who took their blood pressure medication, who got their cholesterol checked, who did not smoke, who tried to eat reasonably, and who were never told that all of those things, while genuinely important, leave a gap. The gap is inflammation. The gap is a $15 blood test that most people have never had. The gap is the conversation between a patient and a physician that keeps not happening because no one knows to ask for it. Ask for it. At your next appointment, ask your doctor to check your high-sensitivity C-reactive protein. Ask where your result falls relative to cardiovascular risk thresholds. Ask what your number means for your specific situation. That one question, asked by an informed patient who watched a video and decided to act, could be the difference between catching something early and learning about it in an emergency room. You have spent the last several minutes with me because you take your health seriously. You are not a passive passenger in the story of your own body. You are someone who shows up, who pays attention, who wants real information delivered with respect. And that is exactly what this channel exists to provide. If this video gave you something you did not have before, a question to ask, a symptom to reconsider, a routine to try, share it with someone you love who is over 60. Not because I need the views, because they need the information. Subscribe if you want to stay in this conversation. And take care of your heart. It has been working for you every single minute of your life without asking for anything in return. Today is a good day to start working for it.